The session which is under the title of Innovations in Diabetes Care. And when the topic was given to me, and I was like, what's the innovation in this topic? And the biggest innovation lies in talking about the female sexual dysfunction. Time and again, we've talked about the male sexual dysfunction, but never with a female centric lens. So here I am thanking the organizers, Banshi sir, Manoj sir, and Purvi ma'am, for a culture that has founded the Kama Sutra. We are a very oversexed culture. We push boundaries in the television, on the OTT. We are still shy in talking about sex amongst the healthcare fraternity, specifically to our patients, people with non-communicable disorders. And it is astonishing to read in the prevalence and the epidemiology during the research for making the presentation that almost 40% of the women are affected with some sort of sexual dysfunction. And a woman's response to any of the troubles is very different. And when we talk about sexual disorders, the understanding of the female first as to what is normal is very tough to define, and then we move on to the disorder part. We have watched series wherein we talk about sex education on Netflix, but nobody talks about the actual normal sex education in our society. And even me, as a doctor today standing in front of you, a lot of the things that I came to know was not even properly in the college. We come to know about a lot of things from our peers. We don't get that proper education which is necessary. Now, when we talk about sexual dysfunction, it's not just a man's world. Female, this is a normal cycle, a sexual cycle. It has 4 phases. But do we all grasp the intensity or the normal physiology of all of these 4 phases? And look at the reporting of this sexual dysfunction amongst women. A lot of us don't know, again, what is missing, what is not correct, what we will call as pathology. And unfortunately, even as a female HCP, talking to my female patients with diabetes or obesity or menopause, it is still not the first question, or even amongst the first 5 questions that we would ask, when was the last time you got intimate with your partner? Let alone if that woman is divorced, let alone if that woman is widowed or in a perimenopausal time. This is not one of the questions that we ask. And it is a healthy thing to ask these questions, to bring them up, because a lot of signs and symptoms are associated with the complications of non-communicable disorders. Diabetes per se is one very important cause of sexual dysfunction amongst women. How do we define this female sexual disorder? So, when we say that there is female sexual dysfunction, it is a continuum of not just physiological disorders, something going awry, but it's a psychosexual disorder that comprises of a continuum of disorders, including the sexual desire being troubled, which is interrelated with problems of arousal, orgasm, as well as pain during the sexual activity. And that in turn impairs the quality of life of this female. Females across all age categories at some point of time have some or the other trouble in any of the phases of the sexual life that we just saw. And it is seemingly sometimes difficult for us to comprehend as well that a female might be going through difficult times, which is associated with that sexual dysfunction, and vice versa, that when she is undergoing something that she's not able to perceive well, she might have some sort of non-communicable disorder. There's only one paper from 2009 which talks about female sexual dysfunction with regards to the Indian population. That paper comes from Dr. Sanjay Kalra sir and the group. And he said that in the North Indian population, 45% of the females suffered from some sort of desire disorder, 62% from arousal disorder, 84% from orgasmic disorder, and 20% from pain. Now, these numbers are too high. And let's take a second to read these numbers again. 45, 62, 84. All of these numbers big numbers for us to even understand that female in such a large percentage go through troubles with desire, with arousal, and with orgasm. A lot of them don't even know what it means. A significant number of female also feel that they are not enough. They have a lower self-esteem. They have body image issues, and they feel that they are not attractive enough for their spouse. And only 3 point something number percent of the women have previously discussed this issue with their doctors, with their gynecologist, or with their physician. Very small number. Again, something that I am asking you to ponder over in the group of these people that we are sitting together, comfortable talking about a female sexual dysfunction. The common type of dysfunction that happen are desire difficulties, orgasm difficulties, excitement difficulties, and sexual pain disorders. Now, when they all come together, they are all interlinked with each other. And there is something known as a hypoactive sexual desire disorder, which is the most prevalent format. And it happens in almost 27 to 52% of the women. It is persistent and sometimes recurrent deficiency or absence of fantasies or desire to engage in sexual activity. This is something that as healthcare professionals, we should bring it up. This is the innovation of conversation that we are trying to bring in our practice for women with diabetes, for women with endocrine pathophysiologies, for women who just come to you and say that there's something wrong with me and I don't know what is happening. Please feel free to initiate a conversation. Now, this is quite common that we were just in the group discussing that there needs to be a paracetamol branded, contraception that needs to come out, and females always have excuses in not engaging. But it's a couple counseling that is required for the man and the woman who are in a relationship and do not have a healthy intimacy on a regular period of time. Now, the hypoactive sexual desire disorder that I'm talking about is one of the most common issue, which is both emotionally as well as pathophysiologically interlinked. Again, what you need to do is question this lady first. Try to find out whether this is a psychological aspect, which is, prevailing for a majority of her time, whether it is a non-communicable disorder like diabetes, hypertension, cardiovascular disease, or obesity, which is prevailing in this lady, or is it something else which we can address? When a woman is going through perimenopausal time or a menopausal time, something which is known as a reverse adrenarche happens. What happens is there are events after the menopause which mirror the adrenarche, and it is associated with reduced DHE and reduced testosterone production. Now, what does that mean? That means that this lady is again not able to understand why suddenly her desire has reduced, why suddenly she's feeling that I'm lost, why suddenly she feels all the emotions that had been very much normal before, and now all she feels like is the 102 excuses that you just saw. But all of these can be significantly addressed. These can be managed well if we know where to pinpoint, where to exactly put our focus and channelize our management on. There are, of course, hormonal mechanism, psychological mechanism, depression and anxiety, and of course, socio-cultural barriers as well that might lead to a female sexual dysfunction. As doctors, hormonal mechanisms, the psychological mechanisms, as well as the depression and anxiety part is something that we need to look on. We can also make changes to the socio-cultural format by not being scared of talking about the most natural thing in a very respectful manner to our females with or without any other communicable disorders. What do we mean when we say that it could be physiological? There could be neurological problems, there could be cardiovascular disorders, urogenital disorders, frequent infections, some medications that could be leading to all of these disorders, fatigue, as well as endocrinopathies. Psychologically, a woman might be going through depression, anxiety, low self-esteem, body image issues, substance abuse. All of these are some of the factors of the iceberg that lead to the female sexual dysfunction. Another important aspect is the interpersonal relationship, how a couple sees each other, how the female feels safe in the environment of what she perceives as her home. Lack of intimacy issues, lack of the feeling that she is in a secure environment, lack of privacy, all of these lead to sexual dysfunction. Some religious values as well as societal taboos are also something that push the lady away from understanding the normal. And if you don't know the normal, you don't know where you're going wrong. What could be the signs and symptoms that we can catch? Some decrease or loss of desire for sex in any format. Please again ask this as one of your leading questions when you're taking history of a female going through menopause, a female with diabetes, or a female with obesity. Inadequate lubrication, vaginal lubrication before or during intercourse. Inability to achieve orgasm is one of the very serious part of the female sexual dysfunction. Vaginismus, which is inability to relax her vaginal muscles enough to allow the intercourse. Pain during intercourse or vulvodynia. Non-coital sexual pain disorder, which is a recurrent and persistent genital pain induced by non-sexual stimulation as well. All of these are some signs and symptoms that we need to look out for. But how should we proceed in case there is a positive response or some ladies coming and saying, yes, I have one of these symptoms? Just ask, screen these females for all the endocrinopathies or any of the factors that you feel might be predominantly present in this female, be it the physiological disorders, be it the depression, anxiety part, be it uncontrolled hyperglycemia or obesity or hypertension. There is a 4-step model that you see. This algorithm is very much freely available on Google. It was in 2019 that the Mayo Clinic people came out with this algorithm. Start with asking the lady some details about her life. Try and again reframe your question so that you can reach up to a very specific concern or very specific sexual problem that she might be facing. There has to be a very empathetic reasoning and empathetic witnessing, and please hear her out. It cannot be just your 3 questions. You will always have to listen to the entire story to understand what is happening. The most important part as diabetologists and physicians is to understand the presence of any other underlying factor that needs to be corrected first so as to have a positive impact on the problem that the female is facing. A very simple protocol over here, find out whether there is an organic cause, a physical cause, or a psychiatric problem, and then think of the treatment, what you want to do, whether you need to treat the underlying infection, you need to send the patient for some physiotherapy, you need to test her metabolic parameters, be it thyroid, be it HbA1c, be it the prolactin levels, and then make a medical intervention, or whether does that patient need more counseling along with a partner majority of the times. There are algorithms, again, very easily available, very easy to follow when we talk about female anorgasmia, which is the inability to arrive or achieve an orgasm. For a similar problem, which is the management of the genitopelvic pain or penetrative disorder in females, again, look for infections first as physicians. Find out if there is any fibrosis or any infections which are recurrently troubling this female, and then decide on what sort of a management you want to take that lady through. There are questionnaires, again, easily available, free of cost available over the internet. The most widely used is the Female Sexual Function Index, or the FSFI, which has questions in the assessment area of desire, arousal, orgasm, as well as pain. Simple questions of all the area, 2 questions each. There are 8 questions. If there is even one question which the lady answers yes, there are follow-up questions. Establish an open dialogue. Make sure that the OPD area is in a private setup wherein the lady feels safe to talk to you about her troubles whenever you are asking her the questions. Make sure if you are a male, you have a female attendant with you to take care that she is feeling safe and secure again to talk to you about her troubles. Management again depends on what is the cause. Find out first what are the cause. There are n number of management available. As a diabetologist, as a physician, it is our first priority to understand and rule out any of the non-communicable disorders. If in an uncontrolled manner, go and control these first. In our practice, it is again important to ask the patient to come back for a follow-up. Ask the lady how she's doing again, whether the management worked or not, whether the counseling was on the positive end for her or not, and give a thorough examination. Refer her to a gynecologist if you do not feel that you are, comfortable enough to do that. The answer lies in early screening, early diagnosis, and appropriate counseling of this lady. All of these being the cornerstones for any lady going through any sort of sexual dysfunction. So with that, I'm going to thank our chairperson, thank Manoj sir, Purvi ma'am and Banshi sir again for including this topic as an innovative conversation that needs to be included amongst all of us. Thank you so much.